Thank you so much for that, Eileen. And may I welcome every one of you to the kickoff season of the Conway Chair Conversation. Happy October to every one of you. I am so excited for all of us to be together and so glad for the topic that our panel is going to present to you today. So I want very much for each of you to know how very welcome you are in joining us. I also would like to share with you the provider unit disclosure that comes from the Division of Nursing. And this is very important for you to know that we do not have conflicts of interest from any of us who are on the panel or any of you who are actually going to be our conversationalists. I do want to let you know that we're seeking your evaluation, and at the very end of our program you will see a link that will take you to that evaluation and you can get C&E credit. And we are in the process of renewing our CME application so that you can also get CME. Just a quick reminder for all of us, the purpose of the Conway Chair Conversation is really to have a back and forth between those of us primarily engaged in research, those of us primarily engaged in clinical care. We want so very much to keep those two groups talking to each other at all points in time. We know that out of that comes better research and as a result, even stronger care. So please know that you have a very important role. Although today I'll be introducing you to our Conway scholars and our panelists, you too have a role as what we call the conversationalist. So in general, we have panelists present information, and then we open it up to all of you as the conversationalists. So you have a very definite role. And you will see us writing down the points that you are making, the questions that you raise. And today, we're really going to be talking about a tough topic, and it is it even possible to protect the sleep of hospitalized children? And you will see today comments that are coming forward from Dr. Nathan Dean, our leader in the PICU, the MUD, and he's going to be talking about an evidence-based approach that he is taking to try to see, can we protect the sleep of children in the PICU? I'm going to offer some comments from past studies about children both hospitalized for scheduled chemotherapy and those scheduled for a transplant, those diagnosed with medulloblastoma. And I'm going to ask the question, can we protect the sleep of children in those circumstances? Very fortunately, Val Rogers came into my life, and she's going to talk about if we can measure it, are we measuring it appropriately? If we can protect, can we measure? And then there's Jurran Wilson, who actually believes we may already have the ability to reach into our electronic health records and extract information that would be about sleep of our children. So we're really very excited about that. And Dr. Danny Lewin is going to join us and really bring home the point about why would we even try to protect the sleep of hospitalized children? After all, they didn't come to the hospital for sleep. But he's going to make some points about maybe we could think about that. So here's the general flow of how we're going to go today. And then you'll notice this big white gap down here. And that's you, all of you who have joined us to raise your questions, offer your comments. And thank you for doing that. So now I'm going to stop sharing, and Dr. Nathan Dean is going to take over sharing and walk us into information and his experience about can we protect the sleep of children in the PICU.
Great, thank you, Pam. Let me get my slides going here. Okay, so I want everyone in the audience here to imagine that you're a patient in the ICU at night. Let's see, okay. It's 8 o'clock in the evening. It's time for your routine pupillary check, your pulse oximeter site's being changed, your blood pressure cuff site's being changed, and the RN beginning a shift assessment is occurring. At 10 o'clock, you're getting an IV antibiotic. It starts to alarm when the dose is finished, and it's time for an albuterol treatment. At 12 a.m., you get another pupillary check. Your pulse ox is changed again. Your blood pressure cuff site's changed again. At 12:30 a.m., it's time for a bath and to have your weight to be measured. At 1 a.m., your Foley catheter is cleaned. At 2 a.m., it's time for your next albuterol treatment and time for an NG tube medication to be administered. At 4 a.m., another pupillary check occurs. The pulse ox site is changed, and the blood pressure cuff site is changed, as are your trach ties. At 4:30 a.m., you get a routine morning chest x-ray that won't be reviewed till about 7:30 in the morning, if not later. At 5 a.m., you get mouth care. At 6 a.m., environmental services comes in to change the linen cart and the trash cans are emptied. It's time for another IV medication that beeps when the pump is finished, and more NG medications are administered. And then at 6:30 in the morning, the physicians and nurse practitioners and PAs are coming in to do their morning assessments as well. I think you guys can imagine that sleep is interrupted quite a bit when your lifestyle is in the ICU. But why should we protect sleep? Kind of the fundamental question that Pam was talking about. Well, first of all, we know that impaired sleep results in delirium. Additionally, delirium and sleep in general are a focus of Society of Critical Care Medicine's most recently published ICU Liberation Bundle. The ICU Liberation Bundle is a set of 6 guidelines that are put in place to help patients get out of the ICU faster and get them up and get them healing faster. And this was studied as a multi-institutional study of 15,000 patients. And they found that high compliance with the bundle was associated with good things. We had decreased mortality, we had decreased days of mechanical ventilation, decreased delirium and coma, and there was an increase in the number of discharges to home compared to a rehabilitation facility. Additionally, we know that delirium is associated with an increase in hospital cost, and that it's been estimated that half $500 million per year in the ICU is associated with pediatric delirium, not just adult, but pediatric delirium. So with that in mind, I took it upon myself to create a quality improvement project in the PICU to help improve sleep for our patients. And what I decided is that I wanted to increase the percentage of patients, or percentage of patient nights that, or sorry, the percentage of nights without awakening events for routine tasks. And this time frame was 11 p.m. to 5 a.m. And the routine tasks I was looking at initially were chest x-rays, baths, being weighed, Foley care, trach changes, twice daily medications, and central dressing line changes. These are all things that could be done outside of the hours of 11 p.m. to 5 a.m. And who am I looking at? I'm looking at PICU patients who are eligible for level 2 or greater early mobilization. This means I'm looking at patients who've been in the ICU for greater than 72 hours, and they have no contraindications, meaning they don't have elevated ICP, their vent settings are moderate and not high, they're not currently under neuromuscular blockade. These are the patients we're focusing on, and there are about 12 to 20 patients each night that meet this criteria in the ICU. And my goal was to increase the percentage of nights without awakenings from 27% to 60%. And I wanted to achieve it by March. I started this a year ago, and I was hoping that I could continue to increase this. So this is a busy slide, and we're not going to go through the entire slide, but what I did was I sat down with experienced and newer nurses who work day and night shift, and we kind of talked about why are we unable to protect this time, and why are we unable to do these tasks outside of the 11 p.m. to 5 a.m. hours. And we kind of focus on issues with staffing, parent interactions, how busy it is in the night shift. Is it safe to retime things or not do certain things or space things out? The culture at night was this is how we do it. And then also whether or not the staff believe if sleep is protected or not. So taking those fundamental points, we created a team that meets regularly and evaluates sleep protection in the ICU. And this is our data. This is a control chart of protecting sleep. I started with my baseline data in September of 2019, and have continued to collect data about 1 week each month. And I've looked at a total of 835 patient nights. So this is real numbers, I think. And you'll see that when I checked the baseline, my center line was about 32%. And not long after implementing the changes and working with our nurses and saying, hey, let's work on getting our baths done earlier. Let's think about sleep. Let's pay attention to who's eligible for protection. We were able to see a center line shift pretty rapidly to 7%, almost meeting my goal. Now we're still below the 80% goal that I set for the summer, and clearly there's more work to be done as we look and see what events are more problematic than others, and we kind of, like I said, meet periodically to discuss changes and what to target. So I'm going to conclude with this slide, some next steps, and I appreciate people's thoughts at the end of this talk about what we're doing and what next steps to do. But what we're going to do is start broadening the number of tasks, because one thing we want to eliminate now are pupillary checks while asleep for the non-neurocritical care patients. If a patient has bronchiolitis and is intubated, do I really need to check their pupils? Probably not, and yet we're still doing that. So let's take that out of the equation. I want to reevaluate patients who receive nebulized treatments during protected hours. Some patients are going to need it around the clock, but other patients you can probably find that protect their time. We're working with others to consider spacing pulse ox and blood pressure cuff site changes and mouth care times to 3 times a shift rather than every 4 hours. Now, clearly, if you're newly admitted and you're not moving, there's concern for wound care issues, and so these need to be rotated. But once you've started meeting this criteria that you've been there for a while, you're getting up, you're moving more, even if you're intubated, we probably can space that to 3 times a shift. So looking at that. And then finally, actigraphy. You're going to hear more about this later from Val, but can we objectively measure the quality of sleep for those patients who we are achieving our goal? We want to see that. So these are the next steps that I'm looking forward to taking and working with the team. Again, it's a multidisciplinary group, the nursing and pharmacy and respiratory therapy. But I personally think that sleep is important in the PICU, and I think it can be protected. And it just takes a little bit of effort to get it done. So with that, I will turn it over to Pam.
Thank you so much, Nathan. So I'm going to quickly summarize on this slide about 4 different studies that were done inpatient with small groups of pediatric oncology patients. And I'm going to give special emphasis to an intervention study that we did with bone marrow transplant patients. We went into this knowing several things. And one was that we had done previous studies with children with leukemia and solid tumors who were in the hospital for scheduled chemotherapy. And we were able to document that they had up to 40 night awakenings. That's a great one to go to the next slide. Yeah, perfect. And so what we learned from these children is that they had a minimum of 15 night awakenings and up to 40, and that they had very poor sleep efficiency. We think of sleep efficiency normally being between 90 and 100%, and they were consistently below 75%. And what happened then with these children is that they were incredibly unlikely to participate in any of their prescribed physical therapy or other forms of physical activity. So we wanted then, I'm going to go back a slide for just a moment, Nathan, and this was to look at these children who were coming in with medulloblastoma. Now, this is a very different group to study sleep with because this is a brain tumor that we know is lodged quite in a location that could affect sleep just by its biology. So we wanted very much to both look at, could we alter the care environment around these children? And we knew from our previous research that certain steroids, primarily dexamethasone, had a tremendous influence on the ability to sleep and by heightening fatigue. And we particularly had studied 2 cytokines, IL-6 and TNF-alpha, knowing that these were quite disturbed during the sleep for children with leukemia and solid tumor, and we had every reason to believe that they would be as well for BMT patients. So on the next slide, what you'll see me emphasizing at the bottom is that we did something very different. We had 2 groups and we randomized them one-on-one to either the intervention arm or to a control arm. We had 37 eligible patients. We actually enrolled about 10 more than that, but a number of those, 9, became quite ill and unable to continue in the study. But every one of the 37 patients wore a wrist actigraph on their non-dominant wrist, and they completed sleep and fatigue and mood age-specific measures routinely. And you'll see here that the mean age was 9.6 years with a standard deviation of 4 years. I wanted to tell you a little bit about the intervention, and this was something that I developed with the night shift nurses on the transplant unit. And we wanted to see, could we create 90 minutes of protected sleep if we bundled our nursing care We thought we could do it. They mapped out, all the nurses on the night shift, what they could do before the 90 minutes and after the 90 minutes. And we talked with parents, explaining that if their child was randomized to the intervention arm, the parent either had to be in the room before the 90 minutes and stay in the room, or stay out of the room for those 90 minutes, that it had to be a pristine, protected 90 minutes. We actually put kind of a soft but thick black fabric that was over the windows between the child's bedroom and the hallway light. And we then asked the child if the child had certain nighttime rituals, and some of these for younger children included book reading, nighttime bath, back rubs, etc. And we did all of those rituals with the child or with the parent. And we then asked the child if the child wanted white noise, and the child could choose from about 22 different types of white noise, such as the rain, crickets, or the ocean sounds. And so what we really learned a great deal about this was that, first of all, the night shift nurses really got into it. They loved the thought that they might be protecting sleep of these children. And then we did an analysis and we looked at both arms of these intervention children. And I believe that might be on the next slide, Nathan. And so what we learned was that the parents reported, who were in the intervention group, that they had never slept better than they did under the conditions of the intervention. And for them, it was the black cloth on the window that they really thought deflected noise and, of course, the light. But regrettably, at least with the analysis that I did with actigraphy in terms of sleep duration, time to sleep, sleep efficiency, waking after going to sleep, no difference between the two arms. And we were, needless to say, stunned. When we looked at all 37 children as a group, we certainly could see that there was a difference with children who had average risk medulloblastoma versus those who had high risk medulloblastoma. But it didn't matter. Neither one had sufficient sleep, with the most being about up to 6 hours of sleep and 24, including nap time. And sleep efficiency, as you can tell, was even lower for adolescents than children. And it concerned us because this was worse sleep efficiency than what we had previously documented with children with leukemia and solid tumors. So clearly we're getting a diagnosis sensitivity in trying to look at sleep. But we were thrilled by the commitment of the night shift nurses to actually create this 90-minute protective sleep cycle. But I was really troubled by not being able to discern differences between the two groups. And I wondered if it had anything to do with the sensitivity of our measures or our expertise. And so I reached out to a wonderful colleague, Dr. Val Rogers, and asked if she would be available to actually do a different analysis of our actigraphy data, and that is circadian rhythm. So if we go to the next slide, this is where Dr. Val Rogers comes in. Val?
Hi, everybody. Thanks so much for having me. So Nathan, click. So first of all, I want to just show you a picture of what the data in an actigraph looks like, because I think a picture is worth 1,000 words. So just to orient you, click. The day, each row is a day. Click. The time is across the bottom, and we have it from 9 p.m. to 9 p.m. So it's a 24-hour period. And the reason that we measured it that way was so that we could portion out the night shift versus, well, the night period versus the day period. So go ahead and click again. Yeah, okay. So the night shift, you can see that it's very messy. The black lines are the amount of activity that's going on in that minute. And normally during your sleep period, there should be hardly any black lines. And during your wake period, it should be solid black lines almost reaching the top. And a normal child would look just like that. But you can see it's kind of messy in this one. So there's a lot of movement even during this night shift. So 2100 to 9 a.m. we decided to make the night time period, and then the daytime period would be 9 a to 9 p. And the reason we did that rather than doing the traditional just nighttime sleep like most studies do is because it was so messy. They were in bed most of the day. There was a lot of activity at night. There was a lot of sleep during the day, and it was really hard to identify where they went to sleep and where they got up. They did keep a diary, but most of the time the diary didn't go very well with the picture. So you can see all the movement here. And I just want to point out the red line, the red arrows on this protocol, the bone marrow transplant protocol. They were getting cyclophosphamide, and they were on a bladder protective protocol where they had to be awakened every 2 hours around the clock to void. So you can see very clearly in this one, although you can't in all of them, where they were woken up. So that is very disruptive to sleep, albeit that it has to be done. Okay, go ahead and click to the next one. So click again. So this is just the first thing we did was we looked at total sleep time. So that's a pretty good thing to look at if you're looking at a 24-hour period, because even though they're sleeping in a very different way than children would otherwise, normally you're awake all day, maybe a little nap for the younger ones, you're asleep all night. Here there was a mix of wakefulness and sleep all day and all night. So 24-hour total sleep time is in the box. And then we compared that to the National Sleep Foundation recommendations for minimum amount of sleep. And I say minimum because there's been a lot of, or when this was published, there was a lot of sort of griping in the sleep research people that this wasn't enough sleep. So recommended sleep is listed under total sleep time, and it goes by age group. And what you can see by the bottom, achieve minimum sleep, is that less than half of the children, despite that we were counting 24 hours worth of sleep, got the minimum recommended sleep they should get for their age. But worst of all, when you looked at who had the least amount of sleep compared to what they should be getting, the preschoolers were seriously affected. So the children 3, 4, and 5 years old, only 14% of them achieved the minimum amount of sleep. You can see that it improved by age. So school-age children, a little over half got enough sleep when you added it together, and teenagers got a little bit more sleep. But you can see preschoolers were a very vulnerable population in this group. Click. So this is a very busy slide, but the sleep variables that Dr. Hinds talked about, like sleep efficiency and wake after sleep onset and so on, didn't seem like it worked that well in this population because there wasn't an identifiable night sleep that you could identify. So we came up with some alternative ways to characterize the sleep of these children and get some information. So percent sleep, how much sleep they got out of the total amount of time, mean duration of sleep. That means for every episode of sleep, what was the average time they slept during that? Sleep episodes, I just want to say, is the number of periods of sleep that are separated by at least 5 minutes. So 5 minutes, you're awake for a pretty long time before you fall back asleep. Now, Cohen's D is an effect size, and you can see the effects are all very little, so they would have to be about 0.5 or higher to be a good effect size. And the difference between the INT or the intervention group and the SOC or standard of care group was not significant in univariate analysis for any of these. Okay, click. So I just wanted to point out, when you look at percent sleep, only just over half of the night period was spent in sleep. So there was a lot of wake time there, but you can also see that during the day, 17 or 18% for each group was spent in sleep during the day, which is also not abnormal. Lots of sleep episodes, at least 12 different sleep episodes during the night. That means that they kept getting woken up and woken up and woken up. So they weren't getting good consolidated high quality sleep. And there were sleep episodes during the day. Click. But the most important and most interesting variable that we ended up finding is the longest sleep episode. So I think, as Pam said, they were getting woken up every 90 minutes, and then the protected sleep period was 90 minutes, and then they'd get woken up again. So how long did they actually sleep during that 90 minutes? So it was pretty low. You can see, well, about, some of them achieved close to 90 minutes of sleep or maybe a little bit over. But let's see, many of them did not achieve that amount of sleep. So probably less than half achieved a period of 90 minutes of sleep, and that varied by study day. So as they got sicker and sicker, fewer and fewer children achieved that amount of sleep. So on day 0, the first day of the study, about 60% achieved at least 190-minute of sleep, and that's only one in the entire 24-hour day. Whereas on day 2, less than half, 48%. On day 3, only a third of the children achieved it, and by the 4th day of the study, that would be day 0, 1, 2, and 3, only 18% got that 190-minute episode of sleep. Okay, click. So it was really discouraging because we didn't find any results just by looking at the sleep variables. So we did some linear mixed modeling controlling for age, because obviously age changes the equation for sleep. And what we found was a significant, what they call group by study day interaction. So at first, the standard of care group was getting a longest sleep, but over the study, their sleep got shorter and shorter and shorter. Whereas the intervention group, you can see there the red line stays pretty horizontal the whole time. So even though it looked like there was no effect of that really great intervention that Dr. Hinds and their group had done, it looks like it did, maybe it didn't improve sleep, but it kept it from deteriorating the way the standard of care group sleep deteriorated. We found the same, very similar thing for the means length of the sleep episodes, but it didn't quite achieve significance, p.08, so a little bit away from being significant per se, but considering there were only 33 children in this analysis, that seemed pretty good. All right, click. So that was the sleep part of the study. We also did, as Dr. Hinds said, a look at circadian rhythms. So circadian rhythms are basically how your body matches up to the Earth's day and night cycle. And that seems like nothing, but it turns out to be probably one of the most crucial things about maintaining health. You have to have a strong circadian rhythm to maintain your health, and there are more and more studies coming out that show that. This picture shows, kind of similar to what you saw before, all those actigraphy lines are all crammed into the 5 days of the study. And you can see that on the picture on the left-hand side, this is a patient who was getting pretty good activity during the day, as you can see by the solid black lines, and at least some sleep during the night. There was still some activity, judging by the black lines that were happening during sleep during those black box periods, but you can definitely see a distinction between day and night and day and night. But when you look at the patient on the right-hand side, if you had to guess where day and night started, you would never know without those white and black boxes underneath. So some of the children looked as bad as that. So it's very clear that their circadian rhythms were very disrupted during this hospitalization. Okay, click. So this is kind of busy, and I did cut out a lot of it out, but of the 6 circadian variables that we mentioned that we had calculated from the activity from the actigraph, we found 3 that were kind of interesting and that showed some promise for future use in studies. One is the amplitude. So that's the difference between the most active part of the day and the least active part of the day. And a very healthy child, there'll be high activity all day long, low activity all night long. So the amplitude will be very large. And now this group didn't do too badly on amplitude, but you can see that compared to other studies under reported CAR cut points, about 112 or 114 would be a normal amplitude, and our kids were getting a mean of about 70 in amplitude. So it was lower than you would expect to see. The second variable, 24-hour autocorrelation, or we call it by short R24, it reflects how stable your circadian rhythm is from day to day to day. And that's important too, because you want high activity during the day, low activity at night, but you want it to look the same every single day. That would be a healthy circadian rhythm. So an R24 of over 0.28 is considered a well-defined CAR in adults. There's no research in children, but 57.5% of the children did not achieve cut point. The dichotomy index, though, was the most important, and that's become a very clinically important variable because it predicts prognosis and it's well associated with disease severity. So if you have 100%, that's really high. What it does is compare how active you are during the day versus how active you are in bed. And well-defined dichotomy index is 93.6 or above, and not a single one of our children achieved that. Okay, go ahead. So this is just, I threw it in just to kind of show the effect. So age had a big effect. So the first 4 pictures, A, B, C, and D, in each of those circadian variables, as the line goes lower, that means the circadian rhythm is getting worse. So as age increased, circadian rhythms got worse for the most part. Click. This one looks like it's getting better, but in fact, it's just scored the opposite of the other one. So this one is also getting worse as age increased. And then the final one, click, is what's called acrophase, and that's the time of day that you have your highest activity. And we know that it gets later and later as you get into teenage years, and that's a physiologic measure. But again, this is just a graph that shows that that was very strong in our study. So in general, as you got older, your circadian rhythms got worse in this study. Okay, click. So I just want to mention, we're talking about sleep, but I do want to mention briefly fatigue. So one of the things that the study looked at was fatigue by parent report and by child or adolescent report. And mainly we stuck with parent report because it was the largest sample. Click. So you can see that all the 3 different fatigue measures, but especially the parent reported fatigue, were associated with various circadian activity rhythm variables. In other words, the more fatigue the children or adolescents got, the worse their circadian rhythms got. So I just want to, that's all I wanted to mention about fatigue, but they're very closely correlated. So our take home, you know, as Pam said, we were very discouraged about the outcomes of no difference, but when you really look closely, you can see there was some difference. This is a really hard group to improve sleep, but I just want to say that when I was in my doctoral program, I did I spent some time in Dr. Danny Lewin's sleep clinic, and one of the biggest take-home messages I got from that really great experience was that no matter how bad the sleep, no matter how dire the circumstances, there are ways that you can improve the sleep, and I think we can do that. Thank you.
Thank you, Val. And now Mr. Jurran Wilson will talk with us about it's possible in the near future that we may already be able to extract from our current documentation in our EHR here at Children's National just glimpses of children's sleep. Jurran.
Thank you, Dr. Hinds. So getting to data, over the last few years, with the advent of our EHR mining platforms such as Trinetics, Healthy Intent, I2B2, we've become very adept at amassing clinical data, and we're starting to learn from it. But we do face some challenges, some very significant challenges with that data. The first is that we actually can't reach all of the data that's been collected in the EHR. So we can reach data that's been collected in discrete fields or fields that are dedicated for a certain purpose. But we also have a lot of data in clinical notes and also in clinical reports that we just can't access. The tools that we currently have can't extract that data and actually combine it and consolidate it. So we face a challenge there. The other challenge we face is that the ability to share this data, even within an institution, within a network, within a consortium, is very challenging. So you face the physical limitations with consolidating this data, requires a significant amount of expertise, also requires a significant amount of funding. You need to do a lot of network building, there's a lot of coordination involved, and one of the most challenging facets is that there's a lot of legal considerations. Hospitals, institutions, you really have to work to share that data, and you have to have legal agreements in place, which can be very difficult. So sharing data is very, very challenging. we have two promising solutions kind of on the horizon. One of them revolves around natural language processing, which you may have heard. It's kind of a key term, hot term right now. And that essentially is the use of AI to help recognize, codify, and analyze human language so that we can take that text data from those clinical reports or from those provider notes and turn it into data that we can actually use. The second promising solution that's on the horizon is something that Children's National and the CTS-ICN have really started to work with are data enclaves, which are basically secure networks where we can share confidential data, where it can be stored, disseminated, and used for a larger purpose. And so that's been used in the past with census data. Different states have used it, the federal government's used it, and the most prominent example right now would be the N3C project, which is NIH's COVID cohort collaborative. And that's led here by Dr. Hiroki Morizono and the CTS-ICN, but it's given us unbelievable ability to share this data. And so the question here is, how does this affect sleep data? How will this help us be able to utilize sleep data that's in the EHR or collaborate with other partners that have collected sleep data? And the simple answer is that hopefully in the near future, we'll actually have the capacity to collect this data in a more robust way. We could take that actigraph data, the sleep study data, EEG data, data from provider notes and clinical notes that we couldn't really access before, and we'll be able to touch that data, extract it, and utilize it. And then also with these data enclaves, we'll have the ability to collaborate in a way that we couldn't before. So sleep data, if you want to do multi-site research with sleep, if you want to collaborate with folks at GW, if you want to collaborate with other colleagues, you'll have an environment in which to do that. So those are the challenges that we face with the sleep data. We actually face those challenges with several types of data, but the future is looking promising.
Jurran, thank you so much. And now we can go to Dr. Danny Lewin.
Great. Good morning. Good afternoon, everyone. Thank you so much for the opportunity to join this conversation, and really want to congratulate everybody on some wonderful work on the inpatient services. If you could advance a slide. I think my slides hopefully will be next. So I want to give you just a very quick overview of some of the basics of sleep that are really essential. And this gets to these issues of measurement, gets to what we prioritize in a bedroom, and then also how we can intervene. So I don't think I can use a cursor to show you anything here. Maybe I can, but across the bottom axis is time, 9 a.m. The dark thick line at the bottom, that's around 10 p.m. till about 8 a.m. Is a sleep period. And then up top, I'm showing you the two sleep-wake regulatory systems. And this is really a gross simplification, but it's important to understand the two of them. On the top, we have process S, which is really the sleep drive, or what we like to call the sleep-a-tite, So we wake up in the morning, and as we progress through the course of the day, we gradually acquire an increasing appetite for sleep. That then is maximal when we go to sleep at night around bedtime, if we've not napped. And then that is relieved very, very quickly. And interestingly, you can see that at about 3 to 4 hours after we go to sleep at night, that sleep appetite has really diminished very, very significantly. And then is, of course, very low the next morning. Now, on the bottom is this other system that you've heard Dr. Rogers and others allude to, and this is the circadian system. And I'll talk about that more in just a moment. I agree with Dr. Rogers that it's absolutely essential. So this shows one of probably tens of thousands, literally, of functions of the circadian system. And this is just the alerting signal. So our alerting signal is actually very, very low in the very early morning hours, gradually increases over the course of the day. There's probably a dip right here, right around siesta time. And then, interestingly, the maximal period of activation for really all of us is right around bedtime. So what do you get when you have a child? I'm sorry, somebody can mute. Thanks. So with the child, what do you get when they're excessively sleepy because they have a high sleep load? but they also have a high alerting signal, this period of activation before they fall asleep at night. You really get a behavioral mess. And those of us who have tried to put our children to bed at night will often see a period of what we call the burst zone of intense activation before they go to sleep at night. So then this period of activation falls off precipitously and is essentially gone by 3 to 4 in the morning, depending on age. And that it should line up with the absence of the sleep appetite from the other system. So this delicate balance between the circadian system and the homeostatic system is really essential, really in everything that we do when we think about maximizing sleep. And one of the key variables that everybody's talked about is maximizing sleep continuity, really to protect a child's sleep when they're on the inpatient unit, and to protect parent sleep. And if the staff, nursing staff, and other staff in the hospital are focused on also maximizing their function, giving them rest and down opportunities also at night is very important. And that's where all of this could coalesce, hopefully, in the near future. Next slide, please. So 3 years ago, the Nobel Prize in Physiology and Medicine went to 3 circadian researchers. And these researchers discovered a series of clock and period genes. So think about the implications of that. That means that every cell in the body is regulating and partially regulated by clock and period. It's a very complex system. There are now many more genes and many more functions that have been identified. This cartoon here just shows a few of the different types of function that occur around the course of the day that are based on these circadian rhythms. And so these cycles are absolutely essential. That's why I said, so consider every cell in the body has a clock. So those cells need to be coordinated within organ systems, however they're specialized. Organ systems need to coordinate. Brain, body, behavior, light. We've got this really elegantly complex system of keeping clock in shape over the course of day and night. And when you think about all of these different functions of the circadian system, and then you think about our kids who are sick in the hospital, not only behaviorally, who are experiencing fatigue, this also raises the question that has probably been around for many years in the oncology field, but less so in other fields, and that is chronotherapeutics. When are our therapeutics most effective? When someone is sleeping, when they're awake, and how does that relate to circadian rhythms and all the functions within each individual cell? Next slide, please. So to wrap up, I just wanted to share a slide. This is based on existing data. The American Academy of Pediatrics and the American Academy of Sleep Medicine has some very broad age groupings for optimal sleep time. We like to break those down because if you're talking about infants 1 to 12 months or 1 to 2 years, we feel really when we work clinically that those are too broad. So we've broken sleep duration need down into much smaller packages. I'd be happy to share this. And then we've added timing. And this is where the field has really lacked. We talk a lot about optimal sleep duration, but what we don't talk about is the essential factor of sleep timing, which changes across the course of development, as Dr. Rogers said, and then daytime sleep need as well. So we need to think sleep duration, we need to think sleep timing, and then we also need to think about the implications and the importance of napping and catch-up sleep. So that's just a super brief overview. I'll stop there to leave lots of time for questions. And Dr. Hinds and organizers, thanks so much again for the opportunity to jump in.
A pleasure, Danny. Thank you so much for being on the panel. So now all of us serving on the panel would like to invite all of you on the line who are our conversationalists to start your videos and to bring forward your questions. You are so welcome to bring them forward with your voice, to put them in the chat box, to raise your hand. We will be monitoring, and we welcome questions, comments, and especially we welcome challenges.
Pam, I have a question. It's Randy.
Hey, Randy.
Hi.
Yes.
Thank you, everyone. This was so nice to hear all the different ways that sleep is being included and important in the hospital. Could you tell me, so after the work that you have done, are there changes that are long standing that the clinical team is now doing? And if you said that, I'm sorry if I missed it, but I just wonder what they now do on the oncology units in terms of trying to solidify sleep.
So I actually did 3 of those studies in a different setting, and because we did not find statistically significant differences, none of those efforts were put into place. But I can tell you anecdotally that when several of the children were readmitted, the families asked if they could be placed back in the intervention arm because it was so positive for them. A side fun note is one little boy chose crickets and for his white noise. And his father was staying with him during the 5 nights of hospitalization, and his father was quite affected by the crickets and really did not want to hear them again for the rest of his days. And we had other parents on the unit ask if we had a cricket infestation because they could hear the crickets. So probably my options that I gave to the children should have been a little more carefully screened for the white noise. But of course, the part about that intervention was a great deal of fun. All of us on the staff really enjoyed it. But I could not tell you if any one of those components was more effective than the other. We considered it kind of bundled care and a bundled intervention. So there's a lot to be learned by taking that apart as well. But I would also say we did very low tech. So we had a piece of paper with a pencil attached to it on the door, and everyone had to sign in and sign out when they went in and out of that room. And parents and staff were almost religious in doing it. Yeah. Very cooperative. Great question, Mandy. Thank you.
And do we have any nurses who are on this call who are providing care to those units now, or overnight, who could tell us what they're usually doing and how they try to preserve sleep, if that's happening now at Children's?
It's a great question. May I ask if there is anyone on the call who is working the night shift and would like to respond to Dr. Streisen's question?
They're all asleep.
No, I think there's some people that may have worked night shift that could maybe step in for our colleagues who may be asleep.
And we had planned to have a night shift nurse with us today, but she couldn't come in the last moment. So I can definitely take your question forward to on several different units. That would be great.
Dr. Hinds, this is Teresa. I'm not generally on the night shift right now, but this work is me thinking a lot about the ED, where, my area of responsibility, where it's normally fast-paced and lots of patients in and out, and there's not sleeping involved. But more and more, we're boarding in the ED because of the limitations on inpatient. So, I'm thinking about how we might do a better job at recognizing these patients or boarding patients, and maybe do something different with the lights or cluster our care differently, which is not something ED nurses normally think about.
Boy, Teresa, that's exciting. We would be your partners in any of that you and your team might be interested in doing. I think, Danny, if you could speak to that 90-minute, we, of course, were thinking about a 90-minute sleep cycle, and that's how we got to 90 minutes. But here at the hospital, we also have some guidance that says PIVs have to be checked every 60 minutes, I believe. And I think, Teresa, you could speak to that. I think Jen Smell is on the line. She could speak to that as well. Is that still current, guys, that every 60 minutes we need to be checking PIVs?
Yes, we need to check as long as there's something infusing. If it's HEP blocked, you don't need to check it every hour.
Okay, that's helpful. Yeah. And Teresa, are your boarders typically with any kind of an infusion or not?
They can be, yes. I mean, sometimes it's just fluid. Sometimes it's an infusion of a medication. Diabetic patients will often be on infusions, and we do get quite a bit of DKA. Patients who might be admitted for hematology oncology, maybe getting intermittent medications. But yes, they could be on infusions.
Thank you for that. Really nice points. Others?
I have a question for Nathan. This is Shauna Jacobs. I'm thrilled to hear about your intervention for the PICU patients, because certainly that is a big area of concern. I'm wondering if the intervention also has a component of what happens during the daytime in terms of turning the lights on and making daytime more daytime, and just to sort of normalize, it seems like it's sort of a 24-hour cycle in there. So, making daytime more daytime while you're making nighttime more nighttime.
That's a great point. So I'm not tracking that data to see if we're doing that, but I know clinically we are pushing that to turn the lights on and trying to orient patients during the daytime to make sure they know where it is. So like one of the things we're doing is changing the order sets around. We've created a new order for the nurses about surrounding nursing or around orientation during the daytime. So lights on day, lights off night, frequent orientation is now part of every patient who's admitted to the PICU. So I think it's definitely important, although not being tracked with my project.
So I'll just jump in and add, that's great to hear that you guys are working on environment. The light is absolutely essential for the regulation of circadian rhythms, as are other factors such as feeding, activity levels, etc. So regulating light and really amplifying the impact of light, regulating noise as well, could also really help to increase the circadian input as well as to protect sleep in general. I'll just say observationally, I also work in the pulmonary division and have historically spent a lot of time on the 7th floor, and often walking into rooms of adolescents on the inpatient service. And those rooms are dark all day. Those kids keep those shades pulled. And they're often up very, very late at night. Their schedules often flip to what is optimal for them biologically or beyond that. So really throughout the whole hospital, with consideration of age, circadian phase for different individuals, these are also very, very important considerations to consider.
And to all of us, has anyone had or has information about what happens to children who are discharged from the hospital? Anecdotally, we have parents telling us that it can take days, weeks, and even months for a child to return to a normal sleep cycle. But has anyone more data about that? I just have anecdotes about that portion. That looks like an understudied area.
Pam, we have a comment from Wendy Fitzgerald.
Oh, good. Hey, Wendy.
And I'll read it. But Wendy, you're certainly welcome to jump in, but I'll go ahead and read your comment. As a nurse practitioner who worked nights for a couple of years, I found that night nurses had what I would call too good of a work ethic. There was a push on their end to get morning labs at midnight so that all the interventions needed could be performed before the morning staff arrived, electrolytes, transfusions, etc. How do we address this? And I think it's kind of the culture of the work environment.
When I met with my team of nurses and we just sat down and said, why does this happen? It was really enlightening, like things I hadn't even thought about. One nurse talked about how she always did her baths at 3 o'clock in the morning because she wanted to hand off a clean patient to the oncoming day shift. Things I hadn't thought about. Another nurse mentioned that sometimes it's really boring at 2 o'clock in the morning and you're trying to stay awake, and so that getting that taken care of. And then also kind of related to like getting the labs drawn, you gotta look and see how the hospital interacts. The lab draw schedule here is at 4 a.m. and it's not something I've tackled because it's outside my sphere of influence. But once I get my other things under control, it's something I want to do. The morning X-rays, the techs want to get these done before 7 a.m. before they change the shift, because during the daytime at 8 o'clock they're downstairs in the radiology world working. So there's a lot of dynamics going on in the hospital that create these issues, and I think you need to sit down and talk to them and explore the more why things happen to figure out how to work around it, rather than just say you just can't tell someone not to do something, because that won't get the job done.
Mm-hmm. Mm-hmm.
We have another question from Susan Keller, who's asking whether or not there's a difference between magnet and non-magnet hospitals with respect to safeguarding patients' sleep. I think Renee's on the line. I wonder if there's any focus on sleep. I guess I'll follow that up with a question about what do nurses actually document in, as far as in the electronic health record? Because I think it would be most likely captured in the note. But I'm wondering if when we do like PIV checks, if there's any sort of incentive to begin to integrate sleep documentation in a structured way in the electronic health record.
Eileen, that's an interesting question, and I'll tell you one area where I believe we do a good job with this is in the ED with our patients awaiting admission to inpatient psychiatry. So we do a good job of getting them on a schedule when they're, because that does impact their agitation level and everything else. So we have certain shower times, we have sleep time, we have activities that go along with that, and then we observe them so closely. Some of them are one-to-one because they're at risk to harm themselves or others, so we document quite frequently what their activity level is, including sleep.
Would be, and so Jurran could look at that, I think, and see what does it show, how does it show up in the record system. Would that be possible, Jurran?
Yeah, as long as it's collected in those fields, it shouldn't pose a problem. We should be able to extract data from that. The problem comes and the challenge comes when it's in the provider notes or the clinician's notes or a report of some type. And so that's where we're hoping that natural language processing, when we actually have that, that'll help us with that.
Thank you, Jurran.
If you'd like to take a look at how we document that, just reach out, let me know, and I'll point you in the direction, because I do believe we have drop-down boxes for some of these, because we set it up that way in part to make sure we're covering all of the areas and activities, hygiene, et cetera, that we offer patients.
Oh, I'd be so
Excellent.
pleased if we could do those kinds of connections from this topic. It's a really important topic, and I think we have a wealth of experts here within our system and opportunities to really do some comparisons across patient groups. I think we're the place and we're the people. So let's see if we can connect in between conversations. I'd like to really thank all of our panelists today and our moderator. This is just a terrific kickoff for our season. I do want to say that the first Tuesday of November is actually voting day. So we will not be having a Conway Chair conversation on that day because we really, really want to support voting in this country. But we will see you again in December. Always feel so welcome to send your potentially interesting and potentially controversial topics to us. We can develop them into a Conway Chair conversation quite happily. My very best to every one of you, and I look forward to being with you again in December, first Tuesday, 12:30 to 1:30 p.m. Please take the best care of you and of each other.
And Pam, can I make one comment? The JOT form, the evaluation form to claim your contact hours is in the chat box. You can click on that link now and it's live and insert your name.
Very special thanks for that, Eileen. Goodbye, all.
Hey, Vicky. I think we're all looking for the link.
It's
You're
towards
muted.
it's towards the top of the chat.
I'm-
Do you see it? Can
The
you
first
scroll up?
chat I see is from Wendy's question.
Let me just highlight it again and put it again. Let's see.
I'm laughing because I apparently got a Zoom upgrade and it's acting really wonky now.
Let's see.
Oh, there we go. Thank you, Eileen.
You're welcome. I think the link disappears when there's more chatting.